We're dietitians, and we've got three small presentations of different innovations that we have put into place. I'd like to start off with the innovations we've done in providing guidelines for GPs and health visitors on the management of cow's milk protein allergy in babies. We see a huge amount of this. It usually takes about 3 months on average for a diagnosis to be made, during which time the parents are going back to the GP on many occasions. The baby is having symptoms of vomiting, diarrhoea, colic, screaming day and night, and it's a really miserable time and worrying time for the parents. There are a whole range of different prescribable formulas that can be used to treat this condition. Or if a mum's breastfeeding, and that's the method we would absolutely want to support, it would mean the mum herself going on a milk-free diet with some calcium and vitamin D supplementation. So we want to get in there as soon as we can so that we can support the breastfeeding. So the guidelines give advice on, depending on the type of symptom and the severity, which type of formula to prescribe, or the advice for breastfeeding mothers. The formulas are listed in cost order, so cheapest first, so hopefully it's cost-effective prescribing as well. Then a referral into the paediatric dietitian, and we then give advice for making sure the treatment is working okay, advice on milk-free weaning, and advice for after a year of age on gradually reintroducing food containing cow's milk, because 90% of these babies will have their symptoms resolved by 2 years of age and hopefully onto a normal diet. So it's one pathway, get the symptoms resolved as soon as possible, cost effective, but as far as quality of life for the family is concerned, it should be really helpful.
Okay. And I'm going to talk about the usage or the dietetic care within a care home setting. When we first came on board into the service, there's a lot of prescribing of nutritional supplements, Fortisip, that wasn't always appropriate for residents, and there was a lot of wastage within the care home setting, and this was obviously money that could be best placed somewhere else. We had sporadic referrals across all the care home settings, so we thought, well, how can we access more residents within that care home setting? What could we devise? So we came up with a design where we felt that we could have a direct referral for the care home setting into our service. So we did a whole load of training with all the care home staff across the whole of the county, which would train them on how to nutritionally screen people using the MUST tool, and then when you're coming up with moderate or high risk, how to implement what we would call food first or food fortification advice, which is actually using things like butter and cream to nutritionally improve the diet, to help to prevent further weight loss, provision of milkshakes, snacks, and to get the care home to look at the menus that they were actually providing for the staff. Once they'd actually implemented that, if the resident was still having weight loss and they might meet the criteria for a nutritional supplement, they could then provide us with a referral which would give us all the details, their 6-month history of their weight. We requested 5 days food and fluid charts so that we could actually see exactly what the resident was actually eating and drinking, and we had all that information in front of us. This came from beforehand what would happen as a dietitian. We'd get a referral, we would track all the way out to the care home setting to find a patient with dementia that we couldn't actually speak to, a carer that didn't know the resident there, no food charts, no history of the weight, and all that was time that wasn't really well spent. We then pick up the telephone and we speak to the carer that's in charge of the resident to devise together a meal plan that's going to be appropriate for their nutritional needs. We then provide a paper copy of that to them, and a letter which then goes to them and to the GP. If nutritional supplements were indicated, we would actually then advise on the type, the quantity, and for how long they should need them for, and we would then continue to monitor that resident until they no longer needed the nutritional supplement, so that everybody that was in that care home setting on a nutritional supplement was monitored by a dietitian. We currently have about 200 residents on our care home database across the whole of the county. The GPs were really pleased with that service,
which they said then is there a way that we can mirror that to the patients that are independent living at home? And we said yes, we do think that's a great idea. Not quite sure how the capacity, because we can exactly do it 100% by telephone. There may be an element that we have to see the patient, and also getting that information in. So what we said is, how can we work with you and doing this? First off is the GP does need to assess that patient. The guidance that we gave them was in paper. That wasn't working. It needed to be in their system. So we worked with we had a lead GP, we worked with the IT service, and we developed a template in System 1 that helped to actually do the must. We taught the GPs how to do the must. It prints off a leaflet. We've asked the GP to review in a month's time, and if that still isn't improving, then to refer. We made the referral system easier with just consent to share, so that we can then see the information, and we didn't have a 7-page reiteration of the same information that we saw. And we've trialed it in the Kettering locality since September. We've done audit to look at what was working, what is not working, and we're now in the process of making improvements, because what we found is that month is too long. We've tightened that up. We're going to do a direct referral. We're going to make the must template easier, and we're trying to do a feasibility. Can we do it county-wide? And that's what we're in the process of doing now.